Hello, everyone, and welcome to the CoROM podcast. This is where academic medicine meets remote, austere, and resource-limited areas. So, good evening from Pretty Bay, Malta. I'm in Malta. Bill Vashis and Dr. Baines are in the U.S., and we have a guest this month. Dr. Baines is a soft doc in active duty with the U.S. Special Forces and former 18 Delta, and he is a specialist in snake envenomations. We'll bring him on. I'm going to give you a brief introduction to our CPG. So each month we talk about a topic on CPG. These are we base it off of the March algorithm, and each of these are the some of the CPGs that are put out using the March algorithm, all the way down to pause and then prolonged field care. Of course, there's tons and tons, and we focus on that. But this week we are going to be focusing on snake. And for those of you who would like to download the spreadsheet I made that allocated the JTS CPGs as March pause and prolonged field care, you can do so. But this time we'll talk about snakes. So this could be a massive hemorrhage problem. It could be circulation problem. So in the March pause algorithm, this is probably going to be mainly circulation. Could get respiratory issues as well, but we'll find out. So Dr. Baines, thank you for joining our CoROM Conversations.
Hey guys, thanks for having me. I appreciate it. This is a topic I care a lot about. Disclaimer, these views are not the views of the Department of War or anybody else, blah, blah, blah. And also I want to be clear that I am not a toxicologist. I'm an emergency medicine physician and an EMS Fellow. And I came at this very much from the operational and pre-hospital side of the house. So I have spent a long time studying snake bites and working with toxicologists. So I'm very comfortable with the management of snake envenomations. But my real contribution to the CPG was talking about how do we operationalize this and how do we consider different skill levels of providers. So that's one thing. The other thing is, please feel free to stop me and interrupt me. I want this to be a conversation, and I'm going to talk kind of where the CPG came from, why it's important, and then talk through a basic approach to snake envenomation. So is this important? Absolutely. There are about 5.4 million bites a year. There are probably about 2 to 3 envenomations a year, and it's probably underreported because many of the regions that have a significant snake envenomation burden are under-resourced and underreported. Many of the places that we might go in the military are places where there is a significant snake burden. And if you're going and kicking around in, the bush or, out in remote and austere places, it may increase your likelihood of contacting some of these delightful little danger noodles. And so it's something that can be very frightening. And it's something that my medics, I got involved in it because when I showed up at my previous unit as a battalion surgeon, I asked my special forces medics, well, hey, what do you guys care about? What should I fix? I work for you. What do you want me to fix? And they were concerned about the snake threat. And so that's how I got to working on this problem. And so it's a fascinating subject. And it's something important. So one of the things that I want you to be familiar with, first of all, is just basic first aid stuff. And there are a lot of myths out there about snake envenomation. So, cutting it and sucking the poison out. People talking about tourniquets are a huge one. And we have a huge problem with people applying tourniquets for snake bites. Freezing it. There's all kinds of crazy things that you'll see that people do. And generally, the most important thing you can do for a snake bite is good quality.
You got muted, Evan.
Okay. I was saying the most important thing that you can do is loosen clothing, remove any restrictive garments, remove any rings or any other jewelry that could be problematic. We do recommend elevating the extremity, and we can talk about why that is if you guys are interested. And basically marking out and doing an assessment for signs of snake envenomation. And that's the treatment for snake envenomation is antivenom. And there are a lot of people who'd like to ask questions right now. There's a lot of stuff in the press about metalloproteinase inhibitors and various universal products that people are purporting that aren't actually antivenom. Because antivenom has this reputation over the years as being, highly reactive and causing anaphylaxis all the time. However, none of those products, what I'll tell a snakebite expert I was talking to made the analogy. He said that some of these new universal products are probably going to be the TXA of snake bites. They're not going to replace the surgeons, but they will probably be adjunctive care or something that can be given while you're waiting to get them to definitive therapy. So anyway, then the snake envenomations are going to fall into different categories. So there's really kind of 4 syndromes that we talk about. We talk about the hemotoxic syndromes, where the venom attacks the blood, and particularly your blood clotting capabilities. We talk about the cytotoxic, where the venom attacks the cells and the tissues and causes tissue swelling, necrosis, and intense pain. And then we talk about the neurotoxic envenomation syndrome, which causes numbness, paresthesias. Often there's some nausea and vomiting associated with it. And then ultimately the way it would kill you is through diaphragmatic paralysis and respiratory failure. And then the other syndrome that we talk about is just the sudden collapse syndrome, which is poorly understood, but especially some of the more serious snake bites will just sometimes cause patients to have systemic collapse and profound shock. And it's unclear how much of that's mediated by anaphylaxis versus potentially other mechanisms. We just don't really know. There are other effects that can happen, and it's important to know that sometimes we make it out like, okay, this snake is going to be like, okay, viper bites are, hemotoxic, and cobra bites are neurotoxic. And it's almost never as simple as all that. The Mojave rattlesnakes also have a neurotoxic venom. Spitting cobras often have a more potent cytotoxic effect than than neurotoxic. So, but in recognizing the syndrome can help you, if you understand the snakes in the region, understand what type of bite you're dealing with. And it can help you choose which antivenom you might need. So I'll pause there for questions. What questions do you guys have about what I said so far?
I would say for planning purposes, if you're going somewhere, you want to do your study and figure out what's the most common snake in the area and what's the most dangerous, and then plan accordingly.
100%. And that's one of the things that the CPG does, is it has very large indices where we break down all of the clinically important snake syndromes that you need to cover in every region and what our recommended antivenom product would be. So if you're going to sub-Saharan Africa, we have, in addition to the treatment algorithms, we have an antivenom selection algorithm where if you're planning, it will tell you what we recommend that you bring with you for different types of snakes and what you would treat different syndromes with in different regions. So that's a really important point, doing your homework ahead of time. This is not something, and it's especially important because in a lot of regions, in Africa particularly, there is a huge problem with counterfeit antivenom, where the antivenom is not antivenom at all, or they will relabel other antivenoms because antivenom is very expensive and not widely available. So be very, very, very careful if you're purchasing this in a underdeveloped country, that much of the antivenom out there is not actually real. You got a hand up?
Yeah, one question from Cole.
Yes, hello. Regarding the antivenom conversation, my understanding is in North America, more specifically in Florida, there's Venom One in Miami that's kind of like one call does it all. We can help you sort of thing for a fee. Does something like that exist in other operational environments around the world? Does Europe have the same sort of thing where you can get reliable antivenom of all varieties?
So there are some organizations that can help you in different regions that could potentially be reliable suppliers, but it's not going to be unified or systematic. I mean, even here in the States, realistically, like, yeah, Venom 1 is amazing and they do great work, but here in San Antonio, I'm not relying on that. One of the good things is, I mean, we have a limited number of snakes in the United States that will bite us, but when we're talking about the exotic snake envenomations, like some dude who's got a mamba, that he handles on YouTube for props, then we really rely on the zoos. And almost every major academic center has a relationship with some of the area zoos where we have a sense of what antivenoms for exotic snake envenomation is available. So we have, like, the San Antonio Zoo has most of the relevant snake. And anybody who has these snakes in any kind of actual zoo setting is legally required to carry the antivenom under a BBIND for any snakes that they maintain. So, but what I'll say is that overseas, it's going to be hit and miss in terms of actually acquiring this stuff. You can talk to organizations like the Asclepius Snake Foundation, who helped us, they were the driving force behind the CPG. And there are other great organizations out there that can help you source reliable antivenom. But it's definitely not something you want to do at the last minute. Any other questions before I move on? So let's pull up the algorithms then. The next slide. So what we wanted to do is we wanted to make algorithms that were usable, accessible, but understand that these algorithms are also, this isn't ACLS. We don't have somebody coding in front of us. That, in some of the cytotoxic bites, in terms of morbidity, long delays can absolutely matter. But this is not usually something where it's going to come down to minutes. So you do have time to sort of sort out what's going on and, choose the right path. So they are necessarily complex algorithms, but they have some basic and simple principles that can help guide you if you understand basically what we're thinking about. So in all of these algorithms, we start with an assessment of, we do our basic, snake bite, our rapid snake bite exam, and, take all the restrictive garments off and all of the things we talked about for basic snake bite care. And then the first basic assessment that we're thinking about in all of these algorithms is there an envenomation syndrome? So are we seeing any symptoms? Was there a bite or was there an envenomation? Because a large portion of bites for many snakes are dry bites. So just even if it's a venomous snake that bit you, it doesn't mean that you actually got the venom. So we want to make an assessment of, is there actually an envenomation syndrome going on or not? And if there's no syndrome going on, then we have an algorithm for monitoring those patients and hopefully returning them to duty. If there is a syndrome going on, then the first question you're going to ask is just stable or unstable. Like, is this patient in a really bad way? So in the hemocyto algorithm, that just means, are they crashing? Are they like having massive hematemesis and bleeding to death and unstable? Or do they have, serious, pain that's gone up like to their trunk and like pain and swelling? Is this somebody who's like really imminently going to have something bad happen? Or are they just symptomatic in the ranges of, lower or higher risk, but they're not crashing? And the difference here is if they're crashing, they're going to get a much higher dose. Usually, I believe it's about double. I'd have to, because it's going to depend on which region you're in, but it's basically doubling the dose of the initial swig of antivenom. And one thing that's important to note on that is the doses that were selected in this CPG were deliberately higher both than many of the box instructions and many of the instructions or many of the protocols that are being followed in places like Africa. Because if you're at the snakebite clinic that Asclepius runs in Guinea, antivenom is profoundly expensive and it's a huge burden. So they're trying to use as little of the product as possible to save a life and prevent morbidity. On the other hand, the U.S. military, when we were writing this, money is a little bit less of an issue than a private snakebite clinic in Guinea. So our dosing is much more aggressive for that reason. And so the difference, if they're stable or unstable, is really just going to be a question of dose. Are you going to do the rocket fuel dose, or are you just going to do still a fairly aggressive dose of antivenom? And then we're going to reassess and determine Is the patient getting better? Is the patient getting worse? Or are they stable? And one of the big questions that you're asking about, you'll see on the algorithms, there's something called the control algorithm. Control is a really difficult question in snake bites. And to illustrate that, I'll talk through a case that I had actually just a couple weeks ago. So a 60 some odd year old Asian woman was reaching into some flower pots and was bitten by a, quote, brown snake in San Antonio, Texas. And she came to us about, 30, 45 minutes after the initial bite. And so we brought her into this was in the emergency department at Brooke Army Medical Center. And so we removed, her jewelry from her hand, took her watch off, made sure she didn't have any restrictive clothing. And she had some fairly significant edema on her hand. We could see the bite marks. There was also a fair bit of bruising already. And there was a small amount of sort of gelatinous blood at the bite sites. It wasn't completely coagulated. And she had stable vital signs. She was alert oriented, everything else. She was not crashing. So what can you all tell me about this? What do you think, what was this brown snake? What are we seeing? Are we seeing, hemocyto? What do you think's going on? Anybody want to be brave and raise their hand?
I'll be your guinea pig. I think it's a cytobite.
Okay, so, we're getting a little bit of both. So we are getting cyto. The cyto symptoms are the swelling and the significant pain in the hand. And what's notable here is the pain was higher up the arm than the actual swelling. So we recommend when we talk about our snakebite exam, we actually draw one dotted line for the pain and one solid line for the swelling and mark it with time, because those are two different things that progress at different rates. So we recommend that you monitor that. So she had that, but we're also seeing some hemo signs, and that's common for these pit viper envenomations, that they're a combination of cyto and hemo. And the biggest thing that we were seeing on the initial exam was the fact that after 45 minutes to an hour, a couple of little, basically needle marks should have clotted by now. And the fact that they're still kind of gelatinous and incompletely coagulated is a sign that there is hemotoxic envenomation present. So then what would be other signs that I would look for in terms of determining what kind of how serious this envenomation is? What might I look for? Okay, we got a hand up.
Yeah, I'll check the respiration rate. It's an indication if the breathing is affected. Then we know it's getting worse and worse.
Yep. So that's it. That's right. That would be a sign. So respiratory issues can be a sign. And there's a great test if you're in a remote environment that you can consider for respiratory. It goes something like this. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, and keep on counting and see how high the patient can count on a single breath. And if they're just counting into teens or single digits, they're probably about to buy an airway, they're about to have respiratory failure. But it's also something that you can chart as you monitor a patient in a prolonged casualty care environment, is do serial exams of their single breath hold test to see whether or not that number is getting lower, because that can give you a hint that we may be headed towards respiratory failure. This lady did not have any, she didn't have any hair sticking up. She didn't have any numbness or paresthesias around the bite site. It was actually intensely painful, even a little bit out of proportion to stimuli. She also didn't have any, decreased respiration. She didn't have any ptosis, which can be a sign. So the drooping eyelids can also be a sign of a neurotoxic envenomation. And then sometimes with the neuroenvenomations overseas, you can even get, they'll also do this crazy nerve gas, type of sludge scenario. The mamba bites, you'll see they're drooling everywhere. It's a hot mess. But anyway, So she didn't have any signs of neuro. She just had hemo and cyto. And then how severe would we say this is, like when we're thinking about the algorithm? Is this patient crashing, or is this patient just, got signs and symptoms of envenomation? Come on. I told you, normal vital signs, normal. Somebody's got to. I don't want to talk the whole time.
I think there's definitely an envenomation.
There is definitely an envenomation, but they're not crashing. This is not in the unstable category. So we're in the stable side of the house. So we ordered up. In our case, we use Anavit. And so this was like right now we're getting on our algorithm, we're getting sort of mild symptoms on our at this time. So we give her 10 vials of Anavit, and then we reassess her on the algorithm a little while later. The other thing I wanted to mention, a great thing to look for the hemotoxic is actually look at their teeth. Bleeding gums can be a leading indicator of systemic coagulopathy. So that's a good one to pay attention for, and then bruising elsewhere in the body. But anyway, so we gave her 10 vials, and however, the swelling and pain had progressed now up above her elbow. Despite the 10 vials of antivenom. So do we have control at this point? No, we do not. At this point, we also got labs back, which you wouldn't have in an austere environment, demonstrating a significant coagulopathy as well, which was concerning. And she was pretty anemic, which was a little bit weird. We weren't seeing any obvious signs of bleeding. She hadn't reported any hematemesis or any, but so it was hard to know what to make of that, but she was, fairly anemic. So at this point, this is a few hours later, we redosed her and we did another round of Anavit. And so we reassessed again a few hours later, but her coags were still getting worse. Her hemoglobin had dropped now almost to transfusion criteria. And so she didn't seem like unstable in terms of vital signs, but so we wound up actually doing a total of 30 vials, which is an awfully big dose of Anavit for a crotalid envenomation here in the States. And then, so my question is, this is one of the really interesting ones. So now her whole arm is swollen and bruised and a hot mess. How do I know when to stop? Does anybody want to guess? Like, what's my stoppage point on this?
When it stops progressing?
Exactly. It stops progressing. And this is really important because I am not expecting this swelling and bruising to go away because of the envenomation. It's going to take days for the swelling in her arm to go down. But that could be one of the really hard things to know with a snake envenomation syndrome is whether or not you need to keep on putting antivenom at them. So we talk a lot in this CPG about control. And then monitoring once we've achieved control. There's a whole separate algorithm for that of, okay, now the symptoms have stopped progressing, or if they were unstable, now we've got them back to the point where they're stable. And now how do we monitor them and decide over the following period whether or not they need to be redosed or whether we've actually effectively neutralized it? By the way, this is an trivia question as a side note on this dosing. How do we dose antivenom? Like, why is it like, do I dose differently for military working dogs or pediatric patients? Anybody want to guess? Man, nobody's raising their hand.
One
You can
size
type
fits
it
all.
in as well, lads. If you want to type it in, we'll read it.
One size fits all.
Yeah, I'm not a mamba. I don't bite. Has somebody typed anything or not yet? One dose. Okay, there's one dose. So the reason why, that's correct. And the reason why is because we're dosing to neutralize a venom administration. So it doesn't matter how big the patient is. We're not doing weight-based dosing for pediatric patients. We are dosing the amount of antivenom it takes to neutralize an amount of venom. So the dosing is going to be the same, whether you're talking about a pediatric patient, whether you're talking about, your military working dog, any of the above, same. So anyway, that kind of walks you through. Now, if this lady had started like throwing up blood or something, she would have moved on to that unstable side, and that would have just pushed us to use even more aggressive dosing. But she didn't. So that's in a nutshell what we're talking about here. And especially once you get past that stable, unstable, really you're just deciding on, am I dosing antivenom and at what initial dose? And then your next, thought point after that is going to be like 30 minutes. So you have 30 minutes to read the rest of the algorithm. It's not going to be something that you're doing in a hurry. So are there any questions on any of that before I move on to talk about neurotoxin?
You mentioned earlier about checking labs in the field. I know if you're worried about cyto progressing to heme or an isolated heme presentation, you can do field dip of a urine, for that, change in the vital signs and progression of systemic cytotoxic to hemotoxic.
There's another test that is also very useful to think about if you've planned ahead for this and you're in a field environment, is if you have or can get access to a clean glass standard test tube. And you can put a couple of cc's of blood in there and monitor it. I'm trying to remember how long the whole blood clotting test is. It's in the CPG.
20 minutes.
I think it's 20 minutes. And you let it sit for 20 minutes. And then if it's not completely solid, there's a coagulopathy present. So that's another way in a remote environment without lab capabilities that you can sort of you field coags and get a sense of, how things are going. So that might be an early indicator that there's a systemic coagulopathy before you're seeing significant symptoms. So another thing that you can consider if you have the access or capability to do it. Again, most of the time it's going to be somewhat apparent, and if you don't have that, it's not a deal breaker, but it could be a nice additional decision-making tool available to you. Just like in the ER, the ability to look at her labs was potentially useful. So it has to be a clean glass test tube with no additives. So, it is literally just a plain piece of glass. So that's, in a nutshell, that's hemo and cyto. And if you're in the US, that's pretty much all of the snakes, because coral bite envenomations are extremely rare. We don't see them often. So that's almost all of the snake bites that you're going to run into in the US, unless it's an exotic. Now, the neurotoxic snakes, this is also something that, so when we talk about hemocyto versus neuro, and again, hemocyto often tend to kind of run together a little bit. Neurotoxic envenomation is much more likely to kill somebody quickly. A black mamba envenomation can kill somebody in under a half an hour. So those are the very scary snakes in terms of rapid mortality. However, it's important to recognize, especially if you're doing operational planning for austere environments, is that not only are the cytohemo snakes much more likely to cause a bite, but there is significant irreversible morbidity associated with delayed antivenom administration in the field. Especially if you're talking about one of the most common places to be bit is like on the fingers or hands. If you have a puff adder in Africa or a gaboon viper and it bites you on the finger or the hand and you have a significant delay to antivenom, there's a good chance you're losing digits. And that can have significant operational implications. And obviously it's just permanent morbidity that we would like to prevent. So when you're thinking about your timeline to antivenom, it's important to remember that, okay, just because, it may not kill, unless it's a mamba bite, it may not kill them in a half an hour, but losing digits, especially if we're talking about highly trained U.S. Special Operations Forces, that's losing a trigger finger is a big bummer. So I thought I'd mention that before I move on. So we talk about the neuro algorithm. And again, we talked about the single breath hold test. We talked about we're doing all of the same things and we're looking for, are they crashing? And, crashing is going to be, vital sign abnormalities. A lot of times they get hyperglycemic. We're talking about blurry double vision, persistent vomiting, and, proximal weakness. One of the really interesting things about the neurotoxic envenomations is the weakness tends to be proximal leading to distal. So you can literally have these patients. So like with the mamba envenomations, which my friend Jordan has done a lot of, and I've seen all these crazy videos he has of these mamba bites. So they get this hypersalivation as well. And the patient is, barely able to maintain their respirations from the central paralysis. They can still use their hands and hold a suction canister. I mean, it's literally to the point where you could almost have a patient bagging themselves because they have central paralysis and inability to breathe, but their hands still work. So something to note when you talk about those neurotoxic envenomations is they're often preferentially central paralysis. So anyway, we're looking for that. And again, hyperglycemia, actually. And I have no idea. And I don't think anybody knows. These venoms are complex protein cocktails that do all of these different things. So they, like the mamba venom, for example, in addition to its neurotoxic properties, has an acetylcholinesterase uptake reinhibitor effect that gives you basically a nerve gas-like syndrome where you're having lacrimation, defecation, and hypersalivation and all of those things. So it's great. You're drowning on your own secretions while your diaphragm is being paralyzed. So not a fun day. That's why mamba bites are so cool, but so terrible. So yeah, a lot of these snakes, they have these really complicated cocktails of different types of proteins. And so that's why they're so interesting. Many medical treatments have come from them, but we also don't understand. Like the mamba bites are one that's notorious for that sudden collapse syndrome where people get bit and just drop dead in under 10 minutes. And we don't really know the mechanism for it. We don't really understand why that's happening. And, again, how much is that like an anaphylaxis type thing or some other protein cocktail that we don't understand? Because even within a single species, within different regions, you'll see slightly different blends of venom. So anyway, no idea, but it can be a sign that hyperglycemia can be an early sign of a lot of these neurotoxic snake bites. So anyway, we're assessing are they crashing or are they just, sick? Are they just envenomated? And then we're going to do either the low dose or the high dose regimen. And we've hopefully already figured that out before we've gone to wherever we're at. And, so basically that's really it. I mean, that's all of the rest of it is just about the reassessments and do we keep on dosing? So it seems kind of intimidating when you look at these big algorithms, but a lot of it is about, okay, what do I do after that first 30 minutes? And when you have a lot of extra time on your hands. And something important that you may have, heard is that I'm not trying to figure out what kind of snake it is in most of these cases. We're trying to figure out what type of envenomation syndrome, because that's going to drive. There's only in the Pacific is there one situation where there's a specific question about what kind of snake might it have been. And we really discourage people from trying to capture the snake. If you can get a cell phone picture of it, that's great. But you wind up getting multiple bites or multiple people bit when you try to capture the snake. So we really, really discourage that. And in the vast majority of places, it's completely irrelevant. I mean, in sub-Saharan Africa, the Polycerp product that we're recommending in the CPG covers every clinically relevant snake in the region. So you really don't even have to know if it's neuro or hemo or cyto. You just have to know, hey, dude got bit and he's having some kind of weird symptoms, and the dosing is going to be essentially the same. So I'll pause there for questions. All right, I'm going to drive on, but you can interrupt me if you were taking your time. So the asymptomatic algorithm is a really important one. And again, depending on if you're in a military context, this was something that I had a lot of a hand in specifically, because I wanted to answer the question about whether what level patients needed to be evacuated to if they were bitten by a snake. And then which of those patients, because dry bites are so common, which of those patients could be kept at the lowest possible level of care and then returned to duty instead of automatically, again, for the US, be it like buying themselves a trip to Germany or something so that we could monitor this, because that's going to be expensive, both in terms of operational and economic costs. So one of the things that we built into the algorithm was this asymptomatic algorithm of how do we monitor people and how closely. So we absolutely are recommending that anybody who's been bitten by a snake be evacuated to a place that has antivenom and emergency medicine level care. So we're talking about in the US, we're talking about getting them back to like a Rule 2. So we want them to be able to intervene if bad things happen. Once they get there, though, we kind of spread it out of if we've gone a certain number of hours, in this case, we say 6 hours, and they still haven't shown any progression of symptoms, then they can't go back to where they came from, to that remote place yet. But like, they don't have to just stay in the Role 2, or they don't have to stay in the clinic after 6 hours. They just have to stay nearby. And then after that, if they've been monitored in the local area where they could be intervened on for 48 hours and they still haven't shown symptoms, they can be returned to duty and go back to their forward deployed environment. So that was an important operational concern that we had, is like, what level of safety are we looking for where we can get people back in the fight? And so that's just something, it basically gives you a framework for how to monitor a patient, because again, remember that dry bites are going to be, in many cases, more common than actual envenomations. Any questions on that? Another important point on the is we talk about antivenom reactions. So antivenom reactions are it's something that people have talked about for years and are somewhat notorious, because does anybody know, like, how do we make these antivenoms? So from venom itself, and I heard, has this been used in South Africa? This CPG was just published a few months ago, so this CPG has not, to my knowledge. But it has. This is all based. The lead author, Jordan Benjamin, who's a good buddy of mine, is a herpetologist and paramedic, interestingly enough, who founded the Asclepius Snakebite Foundation, and he runs snakebite clinics in Africa. And he goes over and just basically goes, especially during the rainy season when snake bites are common, and just he's treated more snake bites than anybody I know, even the toxicologists. And so him, along with, guys like Spencer Green and some of the other luminaries in the toxicology community, came up with this. But I don't think it's been in South Africa. In terms of the how we get it, so yeah, we take the snakes, we get the venom, and we inject it into animals. Antivenom is still prepared from the serum of animals. And the way we make so you have monovalent antivenoms, which means one snake species, and polyvalent antivenoms, which is multiple snake species. And literally, they are taking, typically horses, as Bill said, and they're injecting small but progressively increasing controlled amounts of antivenom into these animals, and then sampling their serum for antibodies. And so the old antivenoms were very impure horse serum, and were notorious for causing anaphylaxis. But what has progressed over the years is the more modern products, like the ones generally recommended as first line in this CPG, are highly purified antibodies against the antivenom. And so the reaction rates are much, 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 much lower than the original ones. It is still the most feared side effect of antivenom. And anytime you're talking about a treatment modality, you absolutely need to be able to handle the complications of that treatment, just like I would expect you to know what to do if you did a procedure like a crike and things went wrong. You would need to know how to respond to that, or you shouldn't be doing the procedure. So we talk about antivenom reactions and how to manage that. And one of the things that's unique about snake envenomation is because there's no other treatment, if they have a severe envenomation, even if they're having an antivenom reaction, we're still giving them more antivenom. We're just giving it with a bunch of epi. So having a reaction is not a contraindication to continued treatment of a snake bite with antivenom. It just means that you have to be prepared for it. And I'm going to go out on a limb and say most of you are comfortable treating anaphylaxis. So I'm not going to beat to death the treatment of anaphylaxis. Although I would say that if you're deploying somewhere remote with antivenom, with a snakebite kit, you need to make sure you have enough epinephrine, not just because we're giving this as an intravenous drug. Like, this isn't just, oh, I've got an EpiPen, I'm good, but making sure you have vials of epinephrine that you could potentially even mix up a real epi drip if you needed it, would be something that I would include in any snakebite kit that included antivenom. So we have the antivenom reactions algorithm. I also don't have a slide for it, but one of the other really important algorithms in the book that I like to talk about is we talk about the tourniquet algorithm. And the tourniquet algorithm, we do not recommend the administration of tourniquets for snake bites. However, especially overseas, it is almost universal that patients will be brought to you already with a tourniquet in place because people think that's what they're supposed to do. And this creates a problem for you because, one, prolonged tourniquet application can be, cause significant morbidity and even mortality. But it also may be trapping that venom that has been, was injected, but now has sort of been saturated through the tissues and into the vasculature, and loosening up that tourniquet may bolus the snake venom and cause a very rapid reaction. So understanding about the pressure bandages, we are not completely convinced in this algorithm that they are effective, but I understand that your protocols may vary. So that's not something that we are typically, I know there are a lot of places that talk about the wraps for the neuro bites specifically, decreasing lymphatic spread, but not usually something that we're talking about in this CPG, although it's very debatable. So, and that's science. Honestly, that was a decision made above my pay grade among the toxicologists. But what I will say is loosening up that tourniquet can be really dangerous. So if we just willy-nilly take that tourniquet off, you can get a very quick and rapid decompensation. And that's something that's been very well described and experienced by my colleagues. So what we recommend is a very dedicated approach of progressive loosening, where you slightly loosen it for about 5 seconds and then retighten it and make sure you're not having any bolus-like effect, and then progressively loosen it for longer and longer periods until you can completely reduce the tourniquet. That way you can control the degree of bolus, and don't loosen the tourniquet until you've already done the rest of your assessment and done all of your other interventions. So anyway, that's just something to be aware of that's also in our Snakebite CPG, is that we do specifically talk about this because it is such a common problem of, okay, I know I'm not supposed to put a tourniquet on, but what do I do with the patient who is brought with one in place? So I think that's, that kind of sums up most of the important parts of the CPG. So I'll, again, take another stop and we'll see what questions we have.
I know in my research a while ago when I was at SOCAF, I spoke to one of the experts down in South Africa named Mike Perry, and the compression bandages and the tourniquets. He has been told and working with other people that the thought was that it would restrict the spread of the venom, but it doesn't have any effect on that. Those compression bandages and tourniquets. That's the venom works faster at the cellular level, not through the vascular system, and it just progresses through. So like having tourniquet on or pressure dressing only compounds the restriction in circulation that the body's doing, which is the edema response that they're having. And it just hurts the patient more than it helps.
And it's also important because hemo and cyto envenomations are so much more common than neuro anyway, that by restricting those cyto effects to a local area, it definitely increases the likelihood of having really severe envenomation morbidity.
Yeah.
And hang on, I saw a question. I'm trying to pull up so I can see the question box. Hang on. Where's my question box? Somebody put something. Would cold compression to the affected limb slow down the effects? So I don't think, my understanding is that there wouldn't be any specific evidence to support that. And again, the compression thing is largely fallen out of favor, although there are still some folks, who are advocating for the wraps for the neurotoxic, but again, not something that's in our, and similarly, icing it down based on the mechanism. I mean, one of the challenges, so one of the reasons why we recommend the elevation specifically as well is, to a certain extent, since hemocyto is so much more common, that trying to restrict the venom to a geographic area is actually likely to cause more harm than good. Now, when I have asked, I asked my buddy Jordan, I was like, okay, gun to your head, you're a snakebite expert and a herpetologist, and if a mamba bit you and you were 3 hours away from antivenom, would you want a tourniquet? And he's like, okay, Evan, as a snakebite expert who can 100% identify the snake and know, and I knew it was a mamba, yeah, I might put a tourniquet on. So some of this, I think I want to be transparent and honest that we're playing the odds a little bit with this. That since hemocyto is so much more common, and since the likelihood of harm is so much higher with that versus very, very niche cases where restricting the antivenom to a local, or restricting the venom to a local area would be beneficial, we are making a judgment call there that we're not recommending that. But that's also why I'm telling you, understand that these are guidelines that are designed to help providers who, in most cases, are not toxicologists and not experts in this area. And this is based on what we feel the best evidence is. But, if you have a toxicologist who wants to deviate from this, or, some other snakebite expert who wants to deviate from this and they have the expertise to back it up, I don't think any of us are claiming universal knowledge and understanding of snake bites, especially since the field, there are so many unanswered questions about how snake envenomation actually works. It's an understudied, under-researched field because it mostly affects poor people in poor countries. And so there's not a lot of investment in it. And that's unfortunate. Question?
Yes, I presume that the question about the delay, the tourniquet, was put in the context of, is it better to lose a limb than to lose life? So will that be a solution?
Well, so like I said, the hemocytobites are very, very rarely going to be rapidly fatal. It's typically going to take many hours or even sometimes days for a hemocytobite to be fatal. Usually the only bites that are typically going to kill within hours are those neurobites. So again, what I'll say is that if you have somebody who can reliably identify the snake and reliably identify the syndrome and the situation. The problem is if you're putting a tourniquet on the neurobites, the other thing, as was mentioned by Bill, is that many of those toxins will still get through anyway. So it's not a fail-safe. But if you reliably know the snake, could it buy you time? Sure. But the problem is that for every patient, I mean, frankly, it's a lot of what we're seeing in Ukraine right now, where people are putting tourniquets on where there was a questionable indication for their use, and then they stay in place for a really long time. And then a patient who had, frankly, a very survivable and non-dangerous injury now is losing a limb because of it. So, again, what I'll say to that is if you have appropriate expertise where you really understand the subject matter and can make an educated risk-benefit analysis of something like life over limb, I think that's fine. But I think if we're trying to talk about this in terms of how do we train large numbers of, pre-hospital providers who have varying degrees of training, I think that perpetuating this, okay, well, we should put tourniquets on because life over limb, is a really dangerous mentality to get into, because it leads to the kind of unnecessary morbidity that we're seeing out of Ukraine. And I'm a big tourniquet guy. Don't get me wrong. I mean, I grew up when they were still scary, and I was there for the transition in our thought process on tourniquets. So I am not running that down, but I am concerned that when we start teaching interventions like that as just the default, especially in resource limited environments where people won't be able to get to higher level quickly, that you could cause some real harm with that as a sort of generalized answer. So hopefully that's not too much, waffling on it, but that's my thought process on it.
I'm not a toxicologist either. Here's why I would not put a tourniquet on, even if I knew it was a neurotoxic bite. If I see that it's a black mamba, I know it's a neurotoxic bite. I see that the patient is going to have an envenomation and they're going to have symptoms from this. I know what's going to kill them, right? If I watch the black mamba bite them because they were fucking around with it, I know what's going to happen here, and I know what's going to kill them. It's the airway, and I know how to control an airway. And so if I have to put a tourniquet on something thinking that it might prevent a problem, what am I first doing? No harm. And so if I add a tourniquet, I am introducing a second complication that I'm going to have to deal with later. Whereas if I keep my problem set at one, and I'm oversimplifying this, but once again, this is my thought process. And if I had to defend it later, then this is how I would do it. I know how to treat a neurotoxic envenomation, obviously antivenom, but while that's getting set up, I'm not going to introduce a second problem that I know I'm going to have to deconflict later. So that's my oversimplification of that answer as a non-toxicologist. Yeah.
Good questions. I mean, this is something that we kick back and forth over and over and over again. And like I said, I kind of put a gun to Jordan's head and I was like, all right, man, like, would you do it? And it's like, okay, but it's such a niche case where it might actually buy you time and not cause morbidity that I think that it would be really problematic to put that forward as a general policy. But understand that these CPGs are just that. They're guidelines, and different providers with different levels of expertise in different situations may need to exercise judgment. This is not prescriptive. This is guidance. But I agree with Bill that I would not put a tourniquet on somebody. Now, it's tricky. One thing that's interesting is I was on the other side of it, Bill, with soft gaff, of arguing with them when they would say, well, why do our medics need antivenom? Because they can just manage an airway. And, my argument is, well, it's a sloppy, hypersalivated, sketchy airway, and is a hole in the neck really going to be preferable to making antivenom available? I felt I thought there was a pretty straightforward answer to that question, but I caught some disagreement on it. And the other thing to remember is, in terms of the delay, is yes, you can keep a neurotoxic envenomation alive for a long time, so long as you can keep on, ventilating them and oxygenating them. However, the longer the venom is active without being reversed, the longer it's going to take to reverse it, and the longer they're going to wind up being in an ICU buying a ventilator. So yes, you can absolutely sustain these patients if you can provide respiratory support. But again, like I said, so this mamba venomation, there's some great videos on the internet if you can look them up, or and Jordan's shown me a ton. I mean, people are literally just having snot and saliva just pouring from their mouth and nose. And so thinking about how you're managing not just the respiratory failure, but that concoction of salivation and snot is going to be a real airway challenge, and it may push you. So they use the eye gels, or try to use the eye gels, but aspiration is an issue there. So that's not a perfect solution. The nice thing is you don't need a paralytic. If you're doing RSI, you can just sedate them. So, I mean, that's an option. But they're very well maybe buying a definitive airway and a ventilator. And again, the longer you leave that venom in place without reversing it, the longer their ICU stay is going to be down the road. So I think that, yes, can you temporize a neurotoxic envenomation? But remember that sudden collapse is also a thing. All of this to say, these were all arguments that I was given against pushing antivenom closer to the front lines. And I am very sensitive to that line of inquiry, because I think that what's important is medics who have the training and have appropriate guidance and support and the ability to treat antivenom reactions can safely have and administer these products. And the answer to days or weeks is it could be weeks if you don't force it quickly. Like if you have somebody with, I mean, people will wind up buying a ventilator for, days to weeks in some cases if they have a prolonged envenomation that's not reversed.
Yeah, I think we've definitely stepped out of the here's the right versus the wrong answer, and we're into the let's choose the least worst option.
Yep.
Of choice. This is not the textbook says do this. This is you're figuring it out on the fly. Yeah,
along
and
with
I think
hypersalivation, you can use neostigmine or atropine as an adjunctive therapy for those kind of bites to help you with secretion control. Something to be aware of that is talked about in the CPG.
Yeah, I think the complication too is having a team versus an individual. If you're a one-person show, you want to minimize the secondary and tertiary effects of treatment and choices. We talked a little bit about this before in the pre-brief, about the confidence to do something and the confidence to not do something. You want to be able to have your best options and understand your limitations. And sometimes that means not doing something because you know that there is complications and secondary and tertiary effects of doing some certain action or procedure. So.
Another thing I wanted to briefly touch on from an operational planning standpoint is I know I have an international audience today, but something to consider is that, at least in the US, so there's no such thing as an FDA-approved COBRA antivenom. So whatever your health regulatory authorities are in your country, it is unlikely that they will have formally approved the antivenoms for snakes that are not present in that country. So in the United States, the only way we can use exotic snake antivenoms in the States is under an investigational new drug license called a BBIND. And this was a major barrier operationally to deploying with antivenom products because the physicians would be like, wait, you want to give non-FDA approved products to our medications to our soldiers? And that became a major emotional event for many people. So something to think about in terms of preparing for deployment and fielding these antivenoms is look into what the regulatory environment in whatever country you're operating in or where you're from is, and make sure that everybody's on board and understands that, this is a niche area that you have to have specific expertise in, and that publications like the CPG should give you a strong backing to use these antivenoms under whatever exception to policy would be present in your home country's system. I hope that makes sense, because again, I don't know exactly where everybody's from, but this can be a huge issue when you're traveling with any kind of regulatory authorities that may be overseeing your medical care.
You're also going to fall within your scope of practice as dictated by your governing authorities and all that fun stuff. So just because you saw it in a podcast, with a discussion by people that that have read a lot and seen a lot, it doesn't change your scope of practice of what you're authorized to do. So obviously everything applies to whatever your restrictions are.
So take-home message. What is the take-home message? So snake bites are interesting. They're a really interesting thing to study. They're understudied. They're a huge problem in developing countries and at a level that we don't necessarily understand. And if you are traveling to remote and austere places, you should be at least thinking about what kind of snake envenomation could be possible and think about what your approach to that would look like. Avoid some of the common myths and pitfalls, like, again, we talked about not putting tourniquets on willy-nilly and all these other things, and cutting in the Sawyer venom extractors and all of that stuff that doesn't work, and finding the right antivenom in a timely fashion and applying it in a deliberate and safe way. So that would probably be my big take home, and I guess that's what I got. And any questions?
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college